Welcome to our video on brain abscesses and spinal epidural abscesses. Let's first just focus on brain abscesses. We'll discuss the definition, pathophys, pathology, how it appears clinically, as well as how you diagnose and manage these abscesses. Okay, so brain abscesses are defined as a focal collection of pus that's in the brain. So fairly straightforward. It's an abscess, it's in the brain, so it's pus in the brain. And this develops as a complication of infection or trauma. And the most common pathogens are Streptococcus viridans and Staphylococcus aureus. Okay, now let's discuss some of the important points regarding the pathophysiology. So what happens is bacteria reaches the brain parenchyma, and it can happen through different ways. The first way is through direct spread from a contagious site. And this usually results in formation of a single abscess. For example, this would be an infection that spreads from otitis media or mastoiditis, and then that leads to an abscess in the temporal lobe. And infection that spreads from frontal or ethmoidal sinusitis can actually lead to abscesses in the frontal lobe. So it's all really logical. So where you start the infection, if it spreads to the brain, then that lobe that's adjacent to the infection is the one that's going to form the abscess. Another way that bacteria can reach the brain is hematogenously. So when this happens, it usually leads to the formation of multiple abscesses in the brain, which makes sense. If there are pathogens traveling through the blood, then the blood can actually spread to multiple parts of the brain and then form infection there, creating pus and an abscess. So it makes sense that if it's spreading through the blood, that you'd have multiple abscesses. Now, some infections that can lead to hematogenous spread of bacteria include bacterial endocarditis and some skin and soft tissue infections. Now, finally, bacteria can invade the brain parenchyma through neurosurgery. And probably the most intuitive of all is penetrating trauma. If you have some gross knife that stabs you in the head, then it makes sense that you're introducing a lot of bacteria. Now let's do a quick question. If given a patient's brain imaging, which shows multiple abscesses, how would it be possible to identify the route taken by the bacteria to enter the brain? Okay, so as we just went over on the last slide, there are three main routes that bacteria can take to enter the brain parenchyma. So there's direct spread, hematogenous spread, or neurosurgery or penetrating trauma. So if you're just looking at the brain scans and you have no other information and you just want to take your best guess, then what you would look for are multiple locations. So if it's multiple, then what are you thinking of? Hematogenous. And if you see a lot of trauma, for example, somebody having a fracture and then there's an infection in the brain near the fracture, then you would think that it was introduced through penetrating trauma. So you can get all that from just the brain imaging. Okay, so given the information, if we were just going off brain imaging, we would assume that this patient's abscesses actually came from a hematogenous route. Now let's talk pathology. On histopathologic examination of a specimen that has been taken from a brain abscess, then the findings actually depend on the age of the lesion. In other words, what you'll see depends on how old it is. So in an early lesion, we're talking the first 1 to 2 weeks, we call this cerebritis. And here there's acute inflammation with localized edema, and there's no necrosis. Also, there'll be predominant infiltration of neutrophils. However, in late lesions, then you will see central necrosis. And then a fibrotic capsule can also form around the lesion. And also, there will be predominant infiltration of macrophages. So a lot of this is pretty intuitive. So early on, there's no necrosis, and you see neutrophils. Later on, there is necrosis because there was time for necrosis to occur. And instead of neutrophils, you get some of the later cells of inflammation, which are macrophages. Now, a patient with a brain abscess most commonly presents with a severe headache. And the headache is usually unilateral, so just one side, and it's resistant to analgesics. And if it's on the brain, then it makes sense that there would be some focal neurologic deficits. So they might have problems with sensation or movement with some part of their body, depending on where the abscess is. And the surface of the brain is considered to be epileptogenic, which means if it's touched, even by pus, then seizures can occur. So now let's discuss how you diagnose a brain abscess. So in the emergent situation, a CT is usually performed first to look for any space-occupying lesions. However, an MRI is the actual image of choice if you're looking specifically for a brain abscess. And there are a couple of reasons for that. One, the MRI is more sensitive than a CT, and it's more accurate for determining the extent of the central necrosis and cerebral edema. In other words, with the MRI, you can tell that there's central necrosis, which would tell you that it's later, or localized edema, which would tell you that it's earlier. Quite logically, a brain biopsy that you acquire during surgery or a stereotactic aspiration is the most accurate method to define the causative pathogen, something that the MRI just can't do. So what you would do is you take the sample and send it for gram stain, and then you would do cultures for bacteria or fungal cultures and mycobacterial cultures. Here's an MRI of a patient with a brain abscess, and note that ringed-shaped enhancement and the perifocal edema. Okay, now let's talk about the management of a brain abscess. It usually combines medical therapy with surgical methods. So IV empiric therapy should be initiated immediately after diagnostic aspiration or open biopsy. And of course, the choice of antibiotics really depends on the results of what you cultured or the gram stain, as well as the source of infection. For example, infections from an oral, otogenic, or sinus source, then metronidazole plus ceftriaxone or cefotaxime are administered. So for infections that spread hematogenously, for example, from endocarditis, then you'd administer vancomycin. And for infections that follow penetrating trauma, then you could give vancomycin plus ceftriaxone or cefotaxime. So that's the empiric therapy. Then of course, once cultures come back and susceptibility results are in, then you're going to tailor that empiric antibiotic therapy to the specific pathogen. And the duration of treatment is actually 4 to 8 weeks. So quite a long time for antibiotic therapy. But I just like to remember that this is in the brain and you want to make sure you've got full penetration. And I just think conceptually, it makes sense that you need to take the antibiotics for a longer period. So 4 to 8 weeks. But what about surgery? Well, this is actually an essential part of both the diagnosis and the treatment. Because one, you need to diagnose the pathogen accurately. So you're going to be doing at least a needle aspiration. And then because it's an abscess, you need to remove it. So if there was an abscess on another part of the body, not the brain or head, then you would do surgical debridement. And really, it's not that much different here. At least the principle isn't much different. If it's in the brain, you've also got to remove that abscess. So surgical excision is often employed. Now let's talk about a different type of abscess, the spinal epidural abscesses. So these are defined as a suppurative infection that forms in the space between the vertebral wall and the dura mater of the spinal cord. So just to help visualize this, here's a representation of a spinal epidural abscess. You can see the vertebrae right here and the spinal cord right here. Also, there is this epidural space that you can see right here. So this is filled with this fat, and hopefully you can appreciate the gap in the epidural space right here. So this isn't normal anatomy, this is an abscess that's occupying this space. So it's on the spinal cord in the epidural space, and it's an abscess. So this is a spinal epidural abscess. So coming back to this definition slide, it's important to recognize that the most common pathogen is Staph aureus. So let's briefly discuss the pathophysiology. So bacteria can enter the epidural space through different ways. First way is hematogenous spread. For example, cellulitis, bacterial endocarditis, or an injection drug use. So those can lead to hematogenous spread of bacteria that can ultimately make its way to the epidural space. The second way is through direct extension from contagious tissues. For example, vertebral osteomyelitis. So far, this actually sounds a lot like how a brain abscess can occur. It can spread through the blood from a source of infection elsewhere on the body, or there's some local infection that spreads locally to the spinal epidural space. And the last way is through inoculation into the spinal canal. For example, when using contaminated epidural catheters. So this inoculation into the spinal canal operatively is very analogous to the penetrating trauma in the brain abscess or the surgical invasion in a brain abscess. So it's basically the same three principles. There are many risk factors of spinal epidural abscesses. So the common ones that you need to know are injection drug use, infective endocarditis, a dental abscess, or a spinal or epidural procedure. And some of the most obvious risk factors are really risk factors for almost any type of infection. So someone in an immunocompromised state, for example, they have HIV, they have diabetes mellitus, or they are alcoholic. So how do these present? Well, the classic triad of a spinal epidural abscess is fever, focal back pain, and progressive neurologic deficits. And these include sensory and motor deficits, and even bladder dysfunction. So let's now talk about the diagnosis of a spinal epidural abscess. So first, clinical suspicion always plays an important role. So focal pain, neurologic issues, and a fever, that should make you think of an infection in the spinal cord somewhere. So once you have this clinical suspicion, then when you get some other labs, they can be helpful. For example, ESR and CRP are usually elevated, and that has increased your suspicion. And what you would want to do at this point is get an MRI. So that's the study of choice. And it's useful for detecting any inflammatory changes even early in the infection. But it's also helpful in determining the exact location and the extent of the lesion. And referring to exact location, it can help distinguish between an epidural abscess versus just soft tissue edema. Now, a CT with contrast can be used when there are contraindications to an MRI. For example, if a patient has a pacemaker or some other hardware metal that prevents them from having an MRI. But just know that the MRI is the study of choice. So here's an MRI showing a lateral perspective of a patient's spinal abscess. So you can see the posterior epidural space and the spinal epidural abscess present there. Okay, so how do you diagnose the actual pathogen? Obviously, you need the MRI. That's a huge part of the diagnosis. But now you want to know what the actual offensive organism is. So you can do this through a blood culture, or you can get a specimen from the actual abscess. Often, both are used. But how do you acquire the specimens from the actual abscess? Well, that can occur during surgery or through CT-guided aspiration. And then just like with a brain abscess, you'd send this for gram stain and then cultures of bacteria, fungal, and mycobacteria. And that's super logical. It's not enough to know that there's an abscess there. You need to know the pathogen so you can actually appropriately treat it. And this brings us to management. So let's assume that you've identified that it is an abscess in the spinal epidural space, and you've seen this through MRI, but you don't yet know the pathogen. So what you're going to do is give empiric antibiotics. And of course, you would want to get the sample first because you don't want the empiric antibiotics to wipe out the bacteria in the blood, preventing you from identifying the causative organism. So it's very similar to meningitis treatment. Okay, so you start the empiric antibiotics, but what are they? This should be vancomycin plus a cephalosporin, either a third or fourth generation. So for example, cefepime, fourth generation, or ceftriaxone, a third generation. Now, once those results from the cultures and susceptibility are available, then of course you're going to tailor the antibiotic management to the causative pathogen. But just like with a brain abscess, you're doing something physically to remove as well. You're not just giving antibiotics. So in this case, surgical drainage and decompression is going to be performed. And you want to do this as soon as possible. And it's actually particularly important for patients with progressive neurological deficits, or any spinal instability, or if you see a ring-enhancing lesion on MRI, or if there's any disease progression despite antimicrobial therapy. And that would be especially scary. That means that you're not treating the pathogen adequately, so you're going to rely all the more on surgical removal and decompression. Now let's wrap up with a board-style question. A 68-year-old man presents to the emergency department with complaints of a severe right-sided headache accompanied by ear pain. Vitals are within normal limits, except for a temperature of 101.2 degrees Fahrenheit, or 38.4 degrees Celsius. The patient notes that he has taken a double dose of Tylenol, which did not help at all. He also appears to be having trouble with his short-term memory. Physical exam reveals a swollen and tender mastoid process. Based on the most likely diagnosis, which of the following treatments is indicated for this patient? A, fluconazole plus cefotaxime, B, metronidazole plus ceftriaxone, C, vancomycin, or D, vancomycin plus ceftriaxone. Okay, so this is an older gentleman, presents with severe headache on the right side, and there's ear pain and a fever. And Tylenol or analgesics did not help. So this presentation, especially paired with the finding of short-term memory loss and a swollen tender mastoid process, should make you think of a brain abscess most likely caused by what type of spread? Direct spread. It's direct spread of the bacteria from the patient's mastoiditis. So if we go back to this management slide, the empiric therapy for a brain abscess differs based on the bacterial route of entry into the brain parenchyma. So in this case, the bacteria likely spread from the brain from the mastoid. So we're going to choose that top option, metronidazole plus ceftriaxone or cefotaxime. So going back to our answer choices, the correct answer is B, metronidazole plus ceftriaxone. Now, answer choice A is incorrect because fluconazole is an antifungal medication which is not indicated in bacterial infections. And that's pretty logical. Answer choice C is incorrect because vancomycin alone is used to treat a brain abscess which occurred in the setting of hematogenous spread of bacteria. But you're not really going to use that if it came directly from a local source like the mastoid. And answer choice D is incorrect because vancomycin plus ceftriaxone is used to treat a brain abscess which occurred in the setting of penetrating trauma. So if penetrating trauma was the most likely route of introducing this bacteria, then empiric therapy would be vancomycin plus ceftriaxone. But since it was local, you're basically doing the same treatment except you're swapping out vancomycin with metronidazole. So the correct answer is B, and that concludes this section.